The sun is still asleep when neurosurgery residents arrive at Carillion Roanoke Memorial Hospital.
I usually get in around 5:30 or 6 in the morning.
We have a list of our patients that we have to see that are either pre-ops or post-ops or trauma patients, just kind of a variety, and we split the list.
And every day is a little bit different.
Good morning.
Good morning. Yeah, I'm Chris Bush. I'm with neurosurgery.
Hi, my name's Farah. I'm one of the residents with neurosurgery.
I'm just checking up on everyone this morning.
How you feeling?
How are you doing?
Let me turn this light off for you.
We'll check on you later. I'll let you get back to resting.
And then when we get together, I've seen my section of patients, and then I report how they're feeling, how they're doing, whatever new lab values or imaging has come up for them since we last saw them, and then kind of make a plan for the day as a team.
It's always, everyone's checking each other. It's just to make sure at the end of the day that you take care of that patient in the best possible way.
Next, the residents go into surgery, where they're partnered with neurosurgeons like Dr. Marvin. The residents also have other duties outside of the hospital, from tumor boards to caring for patients in the clinic to the classroom.
You have academics every week that you have presentations that you have to create. You have your research that you have to be working on outside of your normal duties at the hospital.
And after a busy day at the hospital, Dr. Bush will take his turn on call.
Sometimes you'll have no surgeries in the middle of the night. Other times you can do 4 or 5 in the middle of the night. It just kind of depends.
A hectic schedule, but these residents wouldn't have it any other way.
What we're going to do is make sure there are any major vessels on the surface. Usually when a brain tumor is found, particularly if it's a cancerous or malignant subtype, you have about 1 to 2 weeks to get that patient on the surgery schedule in order to expedite their care. Many times they're under general anesthesia, but sometimes they're under awake surgeries, which I also perform. And then what we do is we use their MRI that they obtained. We load it into the system in surgery for GPS to the brain to actually figure out exactly where we need to make our incision. We clean and prep everything. We make the incision, perform the craniotomy where we take off the bone flap, and then we open the dura, which is the covering of the brain, and we go and take out the tumor. We're going to bring in the microscope in a minute. We're just trying to get this big mass out. The main goal of it is to remove the tumor as much as you can without causing the patient any neurological deficit. And then once you've completed the surgery, you close everything back up. You put the bone back on, you close up the scalp, wake them up from anesthesia, and see how they're doing.
We consider the surgical repair of aneurysms one of the most definitive forms of treatment, meaning it's very unlikely that the aneurysm would recur or regrow. With traditional surgery or microsurgery, we make an incision in your scalp and go inside the skull to identify the aneurysm and essentially clamp it off. The surgical treatment is done in the hospital under general anesthesia, which means you're completely asleep during the entire procedure. An incision will be made on your head, and there may be a small visible scar. And then an opening or a window is made in the skull. The aneurysm is identified usually underneath the brain or between the lobes of the brain. And then using a powerful surgical microscope with a bright light on it, we identify the aneurysm and place a small metal spring clip on it to pinch it off. We confirm that the aneurysm is repaired during surgery by visual inspection under the microscope, or with x-rays. Only after we're completely satisfied with the repair will we then proceed with closure. Most patients are fully awake after the procedure and usually able to be up in the bed or up to a chair that evening and able to have a light supper like broth or soup. The next morning we'll ask you to get out of bed and at least walk to the bathroom or a short distance in the hallway, and most patients then would go home on the third day.
Dr. Jean-Marc Voyadsis, a neurosurgeon at Southern Maryland Hospital Center, is performing a laminectomy to treat lumbar stenosis, a narrowing of the canal within the spinal column that houses and protects the spinal nerves. With the patient lying face down and asleep under general anesthesia, Dr. Voyadsis makes a small incision in the patient's back, using X-ray guidance to locate the precise area of the disease. Dr. Voyadsis then uses a series of tubular dilators to create a narrow working corridor through the patient's back. The tubular dilators allow him to access the stenosis without damaging supporting structures of the spine, such as the surrounding muscles and ligaments. Using a surgical microscope, Dr. Voyatsis then performs a laminectomy by removing the bony wall of the narrowed spinal canal. This is performed with a high-speed drill and a series of surgical instruments that are deployed through the working channel. Kerosene rongeurs are used to carefully remove the thickened ligaments within the canal that are causing the nerve compression. After confirming that he has successfully achieved a complete decompression of the nerves within the spinal canal, Dr. Voyatsis removes the working channel and closes the small incision.
Neurosurgery requires long hours. Doctors often perform multiple operations a day. Stressors include having someone's life or, at minimum, a patient's cognition in their hands.